Hi, my name is Sandy Hanson. I am the medical director for the stroke program at United Hospital, and I'm coming to you today to talk to you about a process improvement, the first in a series of process improvements to our stroke code process that I believe is going to make a big impact on our patients' lives. So currently, our stroke code process is set to achieve a goal of 40 minutes. Try as we might, we haven't been able to get our average door-to-drug time down below that average. And we believe the problem is because we have two separate processes. We have the process in the field, and then we have the process in the hospital, and we need them to overlap. The best practices across the country and across the world are using a model of going straight to CT and looking to take parts of the stroke code in the emergency room and place them out in the field where you are. And what that means is improved communication with EMS and the emergency room. So the aim of this project is to decrease average door-to-needle times in ischemic stroke patients receiving IVTPA treatment in the United Hospital emergency room from 40 to 30 minutes over the next 3 months in patients delivered by Allina EMS to United Hospital. Remember that every 15 minutes saved is a 5% relative decreased risk of dying from stroke during that hospitalization. So all these minutes matter. Building off the Helsinki model, what we hope to do is move some of our stroke code out into the field. By this I mean, with additional information that you offer us from the scene, we're able to prepare and start our code process while you're still on the scene and bringing the patient in. So the additional information includes the following. Already you may be giving us the patient name and their date of birth, the symptoms and signs. Give us some more details about time last known well as outlined on this card. Give us your cell phone number so the stroke neurologist can call you back and have a one-to-one conversation with you and get high-value information. Give us their blood pressure so we can ready blood pressure treatment while you're coming in. Let us know if they're on an anticoagulant, any of these new anticoagulants. Give us an estimated weight. In some cases, we might even be able to mix drug early if we have a high-value candidate that's likely to require IVTPA. So what's new and what do we need you to do more of in our stroke codes? Call the emergency room early. The more the time we have to prepare, the better prepared we'll be to move the patient straight to CT scan. Initiate the stroke code if the symptoms are within 7 hours of last known well, or if the patient woke up with a stroke and they're within 7 hours of waking up with it. Give more information to help us move the code forward in the ED. Accept the call back to yourself from stroke neurology as you are en route to have enhanced exchange of information. Limit the time on scene if you can, so maybe consider doing the 12 lead in the rig if you can. And then meet the ED doc at the door and we'll go straight to CT with you in these cases. In order to call a stroke code, you need to be able to recognize it, right? So I'm going to give you a little primer on stroke recognition. First of all, there's the common symptoms, including sudden onset weakness, numbness, speaking problems, seeing problems, trouble walking, dizziness, loss of balance, sudden severe headache. Those are the symptoms. And then your exam, utilizing the Cincinnati Pre-Hospital Stroke Scale, you hone in on facial droop, arm drift, and speech. But remember, the Cincinnati Pre-Hospital Stroke Scale is recognizing the most common symptoms. Approximately 80% of stroke symptoms might have one of those features. But what about the other 20%? So I'm going to cover for you serious cases that we sometimes miss in triage that go a little bit beyond the Cincinnati Stroke Scale. First of all, aphasia. If it's a language disturbance that is in the posterior temporal lobe, in middle cerebral artery territory, it can look like a delirium. So if you have a patient with confused speech, but lots of it, ask them questions to gauge their comprehension. A visual field cut isn't always recognized by the patient. They can look perfectly normal. So that is missed and sometimes thought of as a migraine if they have nonspecific visual complaints. That's a large stroke in the occipital lobe of the brain. If you have a patient with spinning dizziness or vertigo, the most common thing to consider is labyrinthitis. But that can actually be a very large stroke in the posterior part of the brain and can be quite dangerous for the patient. You would think that in the case of a brainstem stroke with basilar artery thrombosis, we wouldn't miss it. But picture for yourself a patient who is found down in a coma posturing. The first thing we think about is seizure. So if you have someone with just tonic posturing, no clonic activity, think about stroke as well. Once in a while, a patient with leg weakness only will be missed because of mistaking the problem for a peripheral nerve disorder. But that can actually be a frontal lobe and a fairly large stroke in the frontal lobe involving the anterior cerebral artery territory. And then lastly, a common finding that you see with motor weakness is a gaze deviation to one side. That also can involve the frontal lobe, but most often the middle cerebral artery territory. And sometimes that gaze deviation is mistaken for a seizure. So how do you avoid missing a stroke? Listen and question the confused patient. Check their comprehension to find the aphasia. Check visual fields. Notice whether or not there's a gaze preference to one side. If the patient is complaining of dizziness, it's usually associated with nausea. If it's a spinning dizziness, think possible stroke. And then in the coma patient, if they're posturing, think stroke, even if your first thought might be seizure. Another thing that's not on the Cincinnati stroke scale is sensory changes. The patients will often complain of these, but it's not measured by the Cincinnati stroke scale. So remember, Cincinnati stroke scale, any one of those features on the exam are going to be important in and of themselves. And then remember to go beyond the Cincinnati stroke scale in your thought process. I can't tell you how important your role in our stroke code process is as we try to improve further and shorten the door to drug time to improve the efficacy of IVTPA. Your part in this is critical. So recognize those strokes and get them in as quickly as possible.